We have Dr. Jason Lerner, who is an epileptologist at UCLA, and he's going to give you guys a talk on understanding your EEG. Thanks, Doc. Thanks.
Hi, thank you everyone for coming. And pictures. How is everybody today?
Good.
So in the past, last year, we did this more as a Q&A session. People had a lot of different questions. Hopefully I could answer. I'll start off by just some real simple basics, because there's a kind of wide range of people usually in the room, from other epileptologists like Dr. Matsumoto over here, who I work with, to people who probably don't know much about EEG at all. So EEG is probably one of the procedures that we do the most of. There's a number of different. Dr. Moshe was was the head of my department when I was my resident a long time ago. So probably the procedure that we do the most of. And what's basically looking at is the electrical activity coming from the brain. And the way it does it, we put electrodes over the scalp, and they're put on with a paste, and we're comparing electrode to electrode. And I think next year I have to bring in we have to get some slides, because it's a lot easier to see visually than to just talk about. But we're basically looking at the activity from one area of the brain to another and comparing it. And in doing so, we can learn a lot of different things. One of the big things we use it for is looking for seizures, and to determine if something is a seizure. So we get a lot of consults, a lot of people coming in for atypical spells or odd spells, doing something that may be a seizure, may not be a seizure. And the EEG is really useful because we put the EEG on and hopefully capture the event while the EEG is on. And during the event, if we can see the seizure, or we may not see a seizure and know that this isn't necessarily a seizure, and this could be something else. It could be behavioral, could be something like a tic, a lot of different possibilities. The other thing which a lot of people don't realize is, while it can be very helpful and sometimes very important to actually capture a seizure on the EEG, it's not essential. And a lot of EEGs can be very, very helpful just looking at what the background activity shows. And so everyone's brain kind of has some regular baseline normal activity. And we can look at that, and depending on age and a lot of different other things, different frequencies are in different locations, and that can help us determine if things are normal or there could be a problem in one spot. Additionally, certain types of epilepsy have very specific EEG patterns to them. So probably the one that people know about the most is absence seizures or petit mal seizures. And they have a very specific background. It's called 3 Hertz spike wave. And what that means is 3 Hertz it happens 3 times in 1 second. And it's a spike wave. So on EEG, we see a very sharp spike and then a little slow after it. And we see 3 of those in a second. And that's classic for childhood absence epilepsy. And so that gives us the definition, the diagnosis right away. Juvenile myoclonic epilepsy is another example where that's similar to the 3 per second, but 4 per second spike wave. Another one, a slow spike in wave, is seen in like schisto syndrome. So these are all syndromes that even if we don't capture a seizure on the EEG, we can get the diagnosis just from what the background looks like. Also, a lot of people have focal epilepsies, so epilepsies coming from one specific part of the brain that may or may not spread. Very often in that area on the EEG, we'll see either some of these spike discharges, we could see some focal slowing, in that area compared to what we expect or compared to areas around it. Or we could see, we don't see the EEG as well. It's what we call attenuated, so it's a little harder to see. And so all these things in one focal area kind of push us in the direction that these seizures are likely coming from here, and that can help us decide whether, what treatment we're going to use, and even for epilepsy surgery. And part of the epilepsy surgery evaluation, probably one of the first things we do, along with an MRI and a PET scan, is video EEG. And for those patients, for the surgical patients, we do need to capture seizures because we need to know where they're coming from when we're going to do surgery, so we can pick as small a spot as possible. So we admit people overnight, and that's people can stay. Usually our patients stay 3 or 4 days. In the adult group, they can stay a week or 2 weeks even to capture seizures. And we capture at least 3 seizures and make sure that they all look alike and they're all coming from the same spot. And then that allows us to say, okay, based on EEG, this patient may be a surgical candidate. Now we need to do other things like imaging. So we need to do an MRI to kind of look at the structure of the brain. We need to do a PET scan, which is similar to an MRI and a CT scan, a CAT scan, except it's looking at more of the function of the brain and how the brain's working. And what it's really doing is it's looking at how the cells take up sugar for energy. And cells that are in an area that could be causing seizures aren't as efficient, and they don't take up this sugar as well. And so we see that in a specific area. And so after doing those 3 procedures, we can have a pretty good idea if this person's a surgical candidate or not. And if they are a surgical candidate, where the surgery possibly could be, and what risks are we looking at. Because depending on where in the brain we're doing the surgery, outcomes and adverse effects are very different. So the EEG is probably one of the first things we do for that. So different types of EEG. There's the overnight EEG I mentioned. There's also routine EEGs, which are usually about 20 minutes. Patients come in as an outpatient, do it for 20 minutes and go home. Again, that is a great study if you're looking at the background. We don't expect to capture a seizure during that for the most part. But again, that can be very helpful. The other thing we do occasionally is ambulatory EEG. And what that is an EEG is hooked up and you're given a piece of equipment to bring home. And the EEG is done at home, and it basically captures the EEG, and you bring it back a day or 2 later, and then we look at it and we read it. And some advantages is you're at home, which is nicer than the hospital. Disadvantages is we're not able to control the environment, so sometimes the quality is not as good, but for certain things it actually can be very, very helpful for. Let's see, what else can I tell you? I've actually been asked this before. So the EEG is basically looking at the activity that's in the brain. It's actually not doing anything to the brain. So people have said that they thought that we were actually, with electricity or something, actually putting something into the brain with the EEG, and that's not accurate. It's just purely observing what's going on in the brain. Doesn't hurt, especially when you're in the inpatient. It gets the sticky stuff that we put in as kind of a paste. Can be a little hard to get out of your hair a little bit, but outside of that, it's a pretty painless procedure and can be pretty quick. Let's see, any questions? Yes?
The last 3 EEGs that I've had, my neurologist, when I asked him about it, they say they came back normal. Mm-hmm. Normal. And he told me that the EEGs have like 5% accuracy or something like that. And he was trying to tell me this before, and he's like, and if you don't not sleep the night before, it goes down even less than that. But can an epileptic's EEG come back completely normal? Is that common?
So, excellent question. I don't know as far as the 5% goes, but one type of epilepsy, focal epilepsy, meaning seizures coming from one spot in the brain and then maybe spreading, very, very frequently we'll see a normal EEG. So that actually helps us in a way that we can say, okay, you probably don't have absence seizures, you probably don't have juvenile myoclonic epilepsy. We know what you don't have based on normal EEG. But the focal seizures we often won't see on an EEG. And those are some situations where the video EEG overnight and lowering medications to actually try to encourage one will help us determine where the seizure is coming from and exactly what type it is.
A focal seizure would be a better candidate for surgery if we could point where the seizure is coming from in the brain.
Yes. So kind of the basics is there's basically 2 different types of seizures if you kind of want to group them together. There's generalized seizures, which basically come from the entire brain at once. And those are not surgical candidates for the most part. There's a corpus callosotomy, that's a procedure that it can be done for very specific seizure types. But the resective surgery, removing part of the brain to stop the seizures, the generalized seizures are not candidates. The focal seizures are candidates, and those are the ones that we like to pick up as early early as possible, find the location, and do surgery. Temporal lobe epilepsy coming from the temporal lobe, so the side of the brain, is probably one of the most common types that we do surgery on, and has excellent outcomes. And then, depending on where the seizure is coming from, again, different outcomes, different adverse effects from the surgery. And we've had patients where the location of the seizure was right smack in the middle of language, and if we did surgery there, we would significantly affect language, and the risks don't outweigh the benefits don't outweigh the risks. So even just because you have focal seizures doesn't necessarily mean you're a surgical candidate, but pretty much every patient with focal seizures that's failed at least 2 medications should be evaluated for surgery. It used to be thought that surgery's the last ditch, and if you can't do anything else, you do surgery. And the thinking now is that that's not the case, and that a lot of people, that is really the definitive treatment, and we should be evaluating it much earlier.
A person with generalized seizures would show activity on an EEG?
The majority of the time, yeah. The majority of the even 20-minute EEGs, you should see an abnormality in the background. So it's helpful to rule those out. She had her hand raised.
What would you say for someone that has multiple foci?
We definitely do see that. A couple things. One depends on where the foci are. We have done surgery. One case I can think of is tuberous sclerosis, where someone had 3 different sites on one side, and we were actually able to go in and remove the 3. It depends on if it's on both sides and where they are. And also which area is actually causing the seizures. So something, again, tuberous sclerosis, there's tubers in the brain, not all of them are causing seizures, and it's important to define which one is causing the seizures. But if it's known that you have some seizures coming from the right frontal, some from the left temporal, usually for the most part, unless the majority of them are coming from one spot, it's a little more challenging, and outcomes aren't as good. But we have had patients where 90% of the seizures came from one spot, and if we did surgery there, we could get 90% of the seizures to go away. And for someone who's having a lot of seizures, that could be very beneficial. But it does make it a little more complicated.
I like complication. Mm-hmm.
Yes, a lot of people in the epilepsy community like complication. They keep us on our toes. Yes.
My son was diagnosed with epilepsy 3 months ago. He had 3 times seizure in May, June, and July. But according to MRI and the EEG, there is no symptom. But doctors said because of the 3 episodes, he should be on medication. So my question is, I just want to make sure, I don't want to have my son, on medication if it's not necessary. What kind of suggestion you can give me to have more tests to make sure? And also,
yeah, I mean it's different. It's difficult to give very specific suggestions because I don't know your son, don't know the whole story. But in general, which we were talking about before, if you get EEG and it's normal, then you now are thinking that's a focal type of seizure, meaning coming from one spot.
It's the partial seizure or something.
So yeah, it used to be called partial seizures or partial complex seizures, and now they've kind of changed the naming to focal seizures, but it means the same thing.
Okay.
So I think there's definitely a possibility that that's the type of seizure, and that's why the EEG was normal. Just because it is a focal seizure type of disorder, MRIs may not be positive. Some of them we can't find. Our technology, we're just not smart enough to be able to find it yet, and we're doing more and more things and more research to be able to do that better. But a lot of cases, we'll do the imaging and we don't see anything, and then sometimes it's just waiting amount of period of time that we do see something or technology gets better. But for the most part, after someone's had 2 seizures, their risks of a 3rd seizure will significantly increase, and after 3 seizures, the risk of a 4th increases. So for the most part, almost all the epileptologists I know and neurologists after 2 seizures would treat, unless there's a specific reason not to. If they were febrile seizures, so fever is specific type of seizures with fever. If they occurred with a head injury, you hit your head and you had a seizure because of that. Outside of those few cases, if we don't have a good explanation of the seizures, then we would treat. But it's important to talk to the your neurologist and
Is it for father this or something?
I'm sorry?
For father this, like you said, sleep overnight and have more EEG or
Possibly. The problem is if you only have 1 seizure a month and we bring you into the hospital for an EEG, it may take 30 days to catch it. So in those situations, it's very difficult to do the overnight EEG because we don't have if someone has a seizure every 3 days, much easier to capture. But in those cases, they're a little more difficult. No, you had a question?
No one ever really explained, but it's on every paper. Everyone says that the background's slowing. What does that mean? But I don't understand, because I get the spikes when they say that there's these spikes, but then there's always that little note at the bottom that says background slowing. I don't know what that one means. So.
Okay, good, great question. A lot of us don't know what it means either, honestly. But what I can tell you is that it's very non-specific, meaning it doesn't mean one specific thing. It's if we see the 3 Hz spike wave I mentioned before, we know that that's absence seizures. Generalized slowing is just something that we see in a lot of people with seizures. We see a lot of people with developmental problems, a lot of people with autism have this. It's a very non-specific finding. And what it means is when we're looking at the background of the EEG, again, I need to bring slides next time because it's a lot easier to see than just talk about. In different areas of the brain, you expect to see different frequencies. And one of the best examples is in the back of the brain, there's something called a posterior dominant rhythm. So the posterior part of the brain, a rhythm that we see when people are relaxed with their eyes closed. And in adults, we expect that to be 9-10 hertz, so 9 or 10 cycles in 1 second. If it's an adult and it's 4 or 5, then that's slow. And in all the different areas of the brain, there are certain frequencies that we expect. And if those frequencies are lower or slower than we expect, then that's what we call diffuse slowing. And so if they're slowing everywhere. But again, it's seen in a lot of different things. So it's not very specific to one thing, and a lot of people's EEGs, we do see that.
Okay. I wondered what that meant. Because, I get the part where they're like, we have the burst of activity for this amount of time, because they give you a little report. But then every report has that, and I was like, I don't know what that is. Okay.
Yeah, it's just that the background rhythms are a little slower than we would expect for age and the location. And again, that just means that there's a problem. It's not very specific to one type of problem. Do you have a question?
In general, I don't know if this is a good question or not, but in general, how often are EEGs done? If my son is okay, 3 months going on, no seizures, and he's doing okay with the medication so far, do they just generally leave it alone, or can you do an EEG just to see if there's anything going on? I don't know if that's a twofold question. If they're okay outside, can there still be things going on that they can check for, or do they leave it alone?
So it's a very, very dependent on each situation.
Yeah.
For most of our patients, if we know the diagnosis, so again, this childhood absence epilepsy patient, for example, I know what his EEG is going to look like if I do it today, tomorrow, 6 weeks from now. For the most part, I'm not going to bother with an EEG because I already know it's there. In that case, what I might do is if the family says, hey, you know what, he's not had a seizure for 2 years, we're thinking about taking him off medication, then we may consider doing a seizure to see what the background looks like. Because that can kind of help us determine when we take off medication, if the EEG is normal, we're looking at maybe 70% chance of not having seizures. If the background's abnormal, maybe 40%. So it kind of helps us with percentages. If things change, so if the seizures look one way and then all of a sudden seizures change and now they're looking a different way, another time we often get another EEG. If another reason someone's doing, getting B's in school and all of a sudden starts getting C's, for no clear. Most people do not have them, but there are some people that do. And when we know that, then we'll often do tests, because the only way we can see if we're treating them correctly is if they're there, and the EEG is the only way to check that. But again, not very common. But for the most part, I mean, there were people who would get yearly EEGs. My wife has epilepsy, and we were somewhere else during my training. She has juvenile myoclonic epilepsy, which is a very specific EEG pattern. She, we were together for 2 years, and each year she got an EEG. And I was only a neurology resident at the time. And I said to our epileptologist, I'm like, well, why are you getting another EEG? Isn't it going to be the same? And I was actually asking because, to learn. And that was the last EEG she got. So, do you need a yearly EEG? Probably not. But again, if things change or you're thinking about doing something different. You're welcome.
So the way that you mentioned that is the grade from A to B. This means if you had epilepsy, your grade can go down.
Oh,
my son
grades.
Always, the grades get A, but kind of is now getting something. So I was just in my mind, does he need to get any evaluation? He does not have any seizure anymore. He's on medication after July. Mm-hmm. So do I need to check it out? But I'm not sure. It's not doing very great in the university.
Mm-hmm. So the thing about epilepsy, which we're learning, and there's going to be more of a push in the future, because it's something that us as doctors have not been doing a great job with, is that epilepsy comes along with a lot of other things. And some of the things that it comes along with are ADHD, learning disabilities, learning problems, depression, anxiety. All these things are a much higher % in people with epilepsy. And we haven't been great about screening for that and looking for that. And we're getting better. But learning difficulties is something we definitely see, as is ADHD or ADD. So it could be related to the underlying epilepsy, whatever's causing that. Some medications can also cause some cognitive slowing, so can make you, actually cause you having problems in school. So most of my patients, if there is any concern about school, I usually suggest an IEP, Individualized Education Program. It's something you can ask the district for, your home district, and it's mandatory. They have to do it. And it's basically an evaluation, an educational evaluation, to see if there's a certain area that you need help in. And then they can help provide that. There's more detailed testing that are available. The UCLA psychology program does it. That does a lot more. It's 2 days of testing, and they often help the school too. The problem is that that's out of pocket. That the insurance doesn't pay for that. But my first suggestion would be, one, look at the medication. Is it, was he doing, straight A's and then you start the medication and now C's, or was it kind of, having problems even before the medication? That kind of can help you rule out the medication as a possibility. But the other thing is to get the district to do an evaluation.
He's in the university, so my question is, if this medication he's taking Kypro, the medication make him less focused, or I'm not sure.
Yeah, it's hard to say. And when we give people medications, we always say, okay, these are the typical side effects that we see. But we know that every patient's different. And even though Keppra is not supposed to cause weight gain, I've got a patient that was perfectly fine and started gaining weight. So we never know how it's going to affect different people. That's not a medication I usually think about causing problems in school. But again, it's something, it's individualized. Yes?
This is kind of specific, but can infantile spasms ever be past H2? Because I've had one neurologist say, my son's totally having infantile spasms, another neurologist says they're epileptic spasms, and they're giving me completely polar opposite treatments.
It's
2.5, so he's right on
right.
the edge. So.
It's a continuum. I mean, some people argue that, they should all just be called epileptic spasms, and that using the term infantile spasms really doesn't necessarily help us at all. Again, depends on the situation. And, at 2.5, I don't know that we would make that much different treatment choices, at that age. It all depends on what's been tried, the underlying cause and things like that. So I wouldn't say that the definition, calling it infantile versus epileptic spasms, they're all basically the same thing. And it's what else is going on along with it is really going to help us decide, our treatment options. So I know I'm skirting the question, but but yeah, I don't know that it is that important. And I'm surprised with, that people would be treating very differently. But other questions? Let's see, is there anything else? Yeah.
So with that, we are going to be starting April, and I've been reading up on it. Should I be afraid of it, or should I just go with it?
I can't give specific advice about medications, but what I would say is that what we believe and what we've seen is that seizures, especially spasms, are typically not treated. We have problems. We see problems, and we believe the treatment does help. So it's again a risk-benefit ratio, but if the benefits are possibly getting rid of the spasms and significantly improving development, that's our goal. And so I use it a lot. There's some concerns. It's something we need to monitor closely. But if we are monitoring closely, we usually catch things if there's a problem. There's some data coming out of UCLA, hopefully in the near future, showing that this peripheral vision, loss may not be as bad as people are making it out to be. So we use a lot of it and haven't had many problems.
Thank you. Appreciate that.
Yeah.
When I was diagnosed at 12, I kind of had the perception that generalized seizures meant were equal to tonic-clonic seizures, and that partial complex seizures were equal to that they were absent seizures, or focal seizures were not the tonic-clonic kind of. Is that true? So if you say focal seizures, can those manifest themselves as tonic-clonic seizures?
Yeah, so the question, if anyone didn't hear, is, as far as generalized seizures and tonic-clonic seizures and focal seizures, can focal seizures look like generalized tonic-clonic seizures? And the answer is yes. And the reason is, the focal seizure may start at one spot, but can spread very quickly. And so you may not even have any clinical findings initially, even if we caught it right at the very beginning, because it spread so fast. Particularly frontal lobe seizures spread really fast. But very often, what looks like a generalized tonic-clonic seizure, most people aren't staring at the person when it first happens. And at the very beginning, maybe there was a movement of one arm first, and then it spread. So to everyone, it looks like a generalized tonic-clonic seizure. So definitely, it's just by, again, this is what I do all day. If you just show me a picture of something, it's really difficult to tell, whether it's a seizure or not sometimes, and even what kind of seizure it is. And that's where the EEG becomes really important. Other questions? Yes.
It's been about almost 20 years since I participated in an MEG study. What's been going on since then?
You've been using MEG for surgical evaluations. And basically, what a MEG is kind of like a combination of an MRI and EEG. Instead of looking at electrical activity, it's looking at magnetic activity that goes along with the electrical activity. Basically, one of the things that it does that we use it for is if we know the seizure is coming from here, from an area this big, the MEG may be able to help us shrink it down and get more focused on where the seizure is coming from. So it can be very helpful for surgical evaluations.
So that's pretty much all in the last 20 years. They haven't gone and used it for, I don't know.
They may be using it for other things. That's what we use it for the most part. It can help with determining where language is, where motor is, but that's all that I've seen people use it for. It may, very well be, it may be used for other things, but do you know of any?
They're using it as a tool for MEG. They're using MEG sometimes as a tool for looking at some of the faster frequencies that are drowned out that are filtered out when we do EEG. But it's mainly all just research-based, not really for clinical applications.
Yeah.
Dr. Leonard, we take maybe one more question?
Sure.
And just wrap it up.
Okay. Last questions, anyone? In the back.
What's your take on marijuana?
I'm sorry?
What's your take on medical marijuana?
Cannabis.
On medical marijuana. Well, for a last question, that's a tough one. So what I usually say when my patients ask me about it is, one, it's another chemical. That's all. It's just another drug. And like all the drugs, some of them work for some patients, some don't work for some patients. I think I'm concerned about using it kind of, I don't want to say haphazardly, but kind of using it willy-nilly. I like the idea of doing the studies. I think that once we're done with the studies, if we look back in 5 years, what I think is going to happen, this is my guess, is that we're going to say, you know what, patients with this disorder, or with EEGs that look like this, Dravet maybe, this seems to help a certain percentage of those. For patients with maybe focal seizures, it doesn't help. And I think it's just going to become another one of the medications that we use on a regular basis for certain patients. But again, we need to know more about it, and that's why we're doing the studies. At UCLA, we have 3 studies that are going to be starting soon for different types of epilepsy. Insurance paying for it? As far as I know, no.
No, I know that, but is that they're just too scared of it, or not?
Well, it's not approved. It's not FDA approved, and so an insurance company is not going to approve anything that's not FDA approved. They're not going to pay for anything like that. So, if at some point it is approved, and when it is approved, then it'll become part of the typical anti-seizure medications that we use. Okay.
Cool. Can you guys give